Okay, good afternoon, everyone. Thank you for being at this session, at this clinical challenge on mechanical ventilation in COPD. My name is Leo Heungs. I'm a pulmonologist, intensivist in Rotterdam. Usually, we actually have two moderators for this session, but I was left all by myself, so it would be very much appreciated if we can make it a little bit more interactive, right? I guess most of us are clinicians. You have your own opinions about mechanical ventilation in COPD, and I think it would make it the most interesting for everybody if we hear different opinions. I mean, there's different ways to treat these patients. So let us just start with a case. So these are my disclosures, nothing related to this presentation, I guess. So in the ICU, we got a female, 65 years of age, with a past medical history of COPD that's quite difficult to control, and she is admitted to the ER. With severe dyspnea, unable to speak, a little bit drowsy, but she's still cooperative. On clinical examination, she's using her accessory inspiratory muscles, actually even using her expiratory muscles, indicating really high load of the respiratory pump. And with auscultation, I'm quite old-fashioned, I'm still using my stethoscope, I hear evident wheezing. There's a tachycardia, and you'll see the arterial blood gases right here. It can be summarized as a hypercapnic acidosis. Chest X-ray, I don't think there's very obvious consolidations, but it's consistent with emphysema, I guess. So I was at the ICU, at the ER with my fellow, and one of the fellows suggests we should start non-invasive ventilation immediately. But then somebody else said, why don't we just try high-flow nasal cannula? It's more comfortable to the patient. Is that a good alternative? So what do you think? What should be our first-line treatment here? Can we have a microphone, please? That would be perfect. You have a microphone? Right here, please. Right here, in the front, sorry.
I think the first line for me is nasal non-invasive ventilation and particularly pressure support.
Right, right. Other opinions? Would anybody favor just a trial of high flow? Any data out there? Is somebody aware of data to show that it is reasonable or effective? That's great, so I can tell you something new. I think this is an interesting study from Ceccara Gregoretti, Paolo Navellesi. It's a multi-center, non-inferiority study in 80 patients, hypercapnic acidosis, with non-invasive ventilation versus high flow. Patients at arterial pH between 725, 735, and the primary endpoint that's important is the difference in arterial CO2 after 2 hours, and the non-inferiority was set at 10 millimeters of mercury. So if you look at the arterial CO2 for both groups, the high flow group, solid, and a dashed line for the non-invasive ventilation, after 2 hours, the reduction in CO2 was actually the same. And that was the primary endpoint, and at the end of the 6-hour period, it was still the same, but we have to be careful because 32% of the patients on high flow eventually needed non-invasive ventilation. So how should we interpret this study? I think, well, and I completely agree with you, with all the evidence out there for non-invasive ventilation, showing that it improves mortality and all other kind of clinical endpoints, non-invasive ventilation should be the first-line treatment. But in patients that do not tolerate non-invasive ventilation, or perhaps in between, at least we have a very reasonable physiological rationale to use high-flow nasal cannula. Somebody who does not agree? Davide, you always have very opposing opinions. You still agree? Okay, so then I guess. Somebody else? Yes, please. Can I have a microphone there?
Generally, the patients who are likely to require NIV after 6 hours are the ones who are really sick. And if they can't tolerate, they are going to end up in that. So it's only going to be a short-term relief, isn't it?
Exactly. Yeah. Yeah, it's a short-term relief. I know, but perhaps, and I don't think they did a kind of sub-analysis, but the patients that had a less severe hypercapnic acidosis may benefit more from high flow. But I think we all know from our clinical practice, it's unlikely that patients can actually tolerate the non-invasive ventilation for 24 hours a day, right? So at least I think it shows that there is a good physiological rationale to alternate it with the high flow. But I don't think the message of the study is that it should be a reasonable alternative as a first-line treatment. But I think it was interesting to actually, well, it's interesting to read the study. We'll continue with the case. And as you can imagine, after 2 hours of high flow, there's a progressive hypercapnic failure, pH 718. So what's our next plan? It's pretty straightforward, I guess, right? I think most of us, if this patient has a full code, we would go to invasive mechanical ventilation. This buys us time for bronchodilation and it avoids further complications. So we sedated the patient, started volume control ventilation, tidal volume 7 ml per kilograms, inspiratory-expiratory ratio of 1 to 5, respiratory rate of 20. Is it reasonable to start with, or would you suggest something else? Looks like everybody is happy, so. But now blood pressure drops. What's going on? Do you have any idea? Exactly. So probably if blood pressure drops immediately after intubation, it's pulmonary hyperinflation, right? I guess most of you are familiar with that. Insufficient time for expiration will result in pulmonary hyperinflation, and that has adverse events, including barotrauma, hemodynamic instability, and as we will address later on, high work of breathing and poor patient-ventilator interaction. So an important question is, how are we going to quantify this hyperinflation at the bedside? Can we? So, yeah, the suggestion right here is to measure auto PEEP, intrinsic PEEP. Any other ideas? Don't you care? I mean, you just leave it like it is, or? So everybody will assess intrinsic PEEP? Okay. Well, we have to think about it for a second, right? Because we are worried about hyperinflation, we are worried about the volume, but we're going to assess a pressure. And I think most of us will indeed assess intrinsic PEEP, but an alternative could be the plateau pressure. So if you want to assess the hyperinflation volume, and it has been done a long time ago in the 70s, 80s, and 90s of the previous century, and what they actually measured was the volume and inspiration, which is the tidal volume and the volume present at the end of expiration. So after inspiration, the patient is completely deflated. So you disconnect the patient from the ventilator, and expiratory volume is measured. That's the volume and inspiration is the hyperinflation volume, but this can only be done when the patient is paralyzed. And at that time, Tuxen demonstrated, but it's in a small number of patients, combination of asthma and COPD, that if your volume and inspiration is below 20 ml per kilogram, then the risk for barotrauma or hemodynamic instability is very low. The question is this superior, because this is very cumbersome. I'm going to show you some data in a minute where we did this, but this is really cumbersome in clinical practice. So is this the same as the static pressures? I'll come back to that for a second, but I think it's good to think for 1 second about what is the definition of intrinsic PEEP? Somebody wants to comment? Okay, so I think in my opinion, intrinsic PEEP, and I think it's important, is the pressure in the alveolus at the end of an expiration. So as you're sitting here in this room, at the end of your expiration, the pressure in the alveolus is 0, equal to atmospheric pressure. But in patients with increased airway resistance, as in this case, at the end of the expiration, there's still a residual pressure in the alveolus. And this residual pressure is called intrinsic PEEP. And that's quite easy to assess, just an end expiratory hold, and you'll see an increase in pressure, and the difference is the intrinsic PEEP. I think most of you will assess it in patients on the ventilator, actually. As an alternative, you could measure the end inspiratory plateau pressure. And perhaps that is even better measure for pulmonary hyperinflation than measuring intrinsic PEEP, what most of us will do, because this is the problem. The problem is that we do not have one intrinsic PEEP. The lung in COPD, but also in asthma, is quite heterogeneous. So there will be areas with an intrinsic PEEP of 3, 5, 15. The problem is, if you have the patient completely expired, what may develop is, what may develop is airway collapse. So you cannot measure the pressure in this alveolus or the pressure in this alveolus. And therefore, from a physiological perspective, it would make more sense to measure your end inspiratory plateau pressure, because you might underestimate the amount of hyperinflation by measuring intrinsic PEEP, by doing an end expiratory occlusion. So if you change, as we will discuss later, tidal volume, PEEP, inspiratory-expiratory ratio, and you want to investigate, you want to see the effect on hyperinflation, is probably superior to look at the effect on plateau pressures compared to intrinsic PEEP due to this phenomenon. And things are actually a little bit more complicated. We recently published this paper, and I'm not going into detail because this is a clinical case, but the bottom line is that the correlation between all kinds of pressures and the volume of end inspiration is pretty poor due to this mechanism. So we're actually measuring completely different things. Okay, so we have already found that mechanical ventilation in asthma and COPD may result in hyperinflation. And for the quantification, I would advise you to use plateau pressures and try to limit these plateau pressures until 28 or perhaps 30 centimeters of water. Okay, so for this case, we measured intrinsic PEEP, and it was 8 centimeters of water. Patient of volume-controlled ventilation, neuromuscular blockade. What are we going to do with the extrinsic PEEP? So we keep extrinsic PEEP at 0, 5, 8, or anything else? 5. So let me ask you, who would say, well, no, extrinsic PEEP is 0? Interesting. 1, okay. So 5. Who's agreeing with this gentleman? A couple of more. 8, just to match intrinsic PEEP. And another method. So what's your? Can we have a microphone, please? What's your other method? Add 1. Add 1 to the intrinsic PEEP. Add 1 to the intrinsic PEEP. So you would go to 9. Okay. Any other opinions or ideas? Okay. The gentleman in the front says 8 to counterbalance the intrinsic PEEP. We have another opinion over there, please.
Titrate, slowly start from 4 or 5 and see what actually the intrinsic PEEP happens.
That's interesting, yes. Because I think this is a very interesting study, and it's only in a small number of patients, but it fits, to be honest, it fits my clinical experience. So what they actually did, it was patients with asthma COPD, controlled mechanical ventilation, and they increased the external PEEP and looked at the total PEEP, but you could say here, because it's the same graph, the hyperinflation volume. Increasing the external PEEP in the whole population increased the total PEEP. Keep that in mind for a second. But then if you look at the individual patients, so these 8 individual patients, right here again, extrinsic PEEP applied as a percentage of the measured intrinsic PEEP versus the FRC. This patient in green, you'll see, any extrinsic PEEP applied will increase hyperinflation. In this, I think, purple patient, applying extrinsic PEEP actually decreases hyperinflation until you're higher than 100% of the intrinsic PEEP assessed. And there are a lot of patients in between. So actually, if you look at this, the effect of extrinsic PEEP on the hyperinflation volume is highly unpredictable because there was no correlation with FEV1 or anything else, any other clinical characteristic. And this study really opened up my eyes, and I think it's exactly as the gentleman said over there. It would make perfectly sense to titrate your extrinsic PEEP and look at the response, just evaluate the response. And most people cannot measure FRC, but you can just look at your end inspiratory plateau pressure, or if you want, at your intrinsic PEEP. Again, I think it basically shows the same. So it's 3 different patients, A, B, C, looking at the lung volume. So some patients, increasing extrinsic PEEP decreases lung volume. In some patients, nothing happens initially until extrinsic PEEP is higher than intrinsic PEEP. And in some patients, there's immediately an increase in hyperinflation with the application of PEEP. Okay, let's go back to the definition of intrinsic PEEP, what you actually would expect from the physiology. I've shown you this. In a patient, normally with normal airway resistance, and there's no extrinsic PEEP, at the end of expiration, the pressure in the alveolus is 0, right? In a patient without increased airway resistance, if extrinsic PEEP of 10 is applied, obviously, at the end of expiration, the pressure in the alveolus is 10 centimeters of water. I mean, that's why you apply PEEP. So, basically, in a healthy lung, if airway resistance is not increased, applying PEEP increases the pressure in the alveolus at end expiration. So now we have this patient with increased airway resistance, even without PEEP. As I showed you before, alveolar pressure at the end of expiration might be 10 centimeters of water. But applying extrinsic PEEP decreases the expiratory driving pressure, right? So it would make sense, and that basically what I would expect, that in every patient that you apply extrinsic PEEP, hyperinflation increases. And that's actually demonstrated right here. So why does in some patients application of extrinsic PEEP decrease the hyperinflation volume? Because that is because of flow limitation. In some patients, because of the external pressure due to the hyperinflation, compression may develop of the small airways. And applying a little bit of extrinsic PEEP actually stents the airways. And the problem is that it's quite unpredictable if your patient is right here or right here. And then it would, again, make perfectly sense to just titrate your PEEP. You start with 0 and increase extrinsic PEEP and find the lowest plateau pressure. That would be a very pragmatic approach. Would you agree, or do you think, well, I don't believe this? Makes a little bit of sense? Perfect. Okay, I'll just skip this for a second. Well, there's a lot of other parameters to set. I think the thing that's important to mention, sometimes people choose to reduce the respiratory rate to, say, 6 per minute. I don't think that makes a lot of sense, right? Because, I mean, look at a typical expiration in a patient with COPD. I mean, if you start the next inspiration right here, or wait until here, the difference in volume expired is really small. So it doesn't make sense to decrease your tidal volume too much. The effect on hyperinflation will be limited. Very important, in the first phase of asthma COPD, we do not care that much about blood gases. The only thing we do during mechanical ventilation is prevent the complications related to hyperinflation, right? Don't worry about a pH. Severe asthma, severe COPD, if pH is 725, 720, I don't mind. Just give the steroids, bronchodilators, and in a couple of days it's probably better. So we're running out of time a little bit. I can like to refer you to this paper. This is specifically not in COPD, but in obese patients. But it shows a large impact of body position on hyperinflation, or basically on the total PEEP. So it's interesting, and I think it's also important in patients with COPD. Try this sitting position. Okay. Happily enough, our patient is improving. We're reducing sedation, stopping neuromuscular blockers, well, the other way around, stopping neuromuscular blockers, tapering sedation, and the patient starts to trigger the ventilator. So what's going on here? The patient is in pressure support. What are we looking at? Yeah, I think it looks like right here, you'll see like there's a kind of interruption of expiratory flow, right? And if I take the EDI signal, the electrical activity of the diaphragm, you'll actually see that this patient has a lot of wasted efforts. The patient tries to inspire, but he can't trigger the ventilator. And why is that? What would be the possible explanations? I'm sure you are aware of it. It's probably intrinsic PEEP. I mean, there's two explanations. Either this patient has a lot of intrinsic PEEP or severe respiratory muscle weakness, right? How do we assess intrinsic PEEP in patients on supported ventilation? That's not that easy. I mean, we cannot do the end inspiratory or end expiratory hold, right? So basically, the only reliable way to measure intrinsic PEEP in a patient on an assisted mode or spontaneously breathing is the esophageal balloon. And then the intrinsic PEEP is defined as the change in esophageal pressure before inspiratory flow starts. And that's how it looks like. Again, this is the patient. Oh, yeah, this is a patient with intrinsic PEEP, 10 of intrinsic PEEP, not connected to the ventilator. So you can imagine every time that the patient wants to start an inspiration, the first thing he has to do is to make sure that the pressure inside the alveolus is lower than airway pressure, because pressure only flows from high to low pressure, right? Air flows only from high to low pressure. So for every breath, and that explains the high work of breathing in these patients, for every breath, he has to overcome this 10 centimeters of water and create an additional 1 centimeters of water before inspiration starts. So that's shown right here. So now we have a patient on the ventilator. It's basically the same thing. For this patient to trigger the ventilator, the first thing he has to do is make sure that pressure right here in the lung is lower than the pressure in the ventilator. So to trigger the ventilator, this patient has to generate a pressure of 11 centimeters of water, right? And if he doesn't, it's a wasted or ineffective effort. And that's exactly why we apply a little bit of extrinsic PEEP when the patient is on a supported mode. I mean, so the setting of PEEP is fundamentally different whether a patient is on a controlled mode or on an assisted mode. Right now, the patient does not have to decrease the pressure until -1 centimeter of water to trigger the ventilator, but only below 8 centimeters of water. So in this case, the patient only has to generate 3 centimeters of water to trigger the ventilator. So the reason we are applying extrinsic PEEP in patients with COPD on assisted mode is to make it easier to trigger the ventilator, right? Does it make sense? Any questions or concerns? Okay. So again, as I just mentioned, the considerations in titrating your PEEP are different in a controlled or in an assisted mode. I'll just skip this for the moment. I mean, it's an alternative to make triggering easier is, if you have the possibility, is using a mode called NAVA. NAVA is a mode that uses the electrical activity of the diaphragm to trigger the ventilator. And the advantage of that is that you do not need to generate a negative pressure to trigger the ventilator. I mean, once there is electrical activity of the diaphragm, you will trigger the ventilator independent of the presence of intrinsic PEEP. Okay. I'll just skip this. So the patient is improving further. We're going to do a weaning attempt. Any ideas? Are we doing a spontaneous breathing trial? Are we just extubating the patients? So what is the idea in the strategy in your ICU? You want to share your experience? I mean, there's not a lot of literature out there, so I think anything you basically do should be good. Oh, so the gentleman, okay, so you perform a spontaneous breathing trial. Okay. Level of support, okay. Okay, so let's see if a patient does a spontaneous breathing trial. I think this is an interesting paper. It opened up my mind again a little bit. Published in The Lancet a couple of years ago, patients with chronic hypercapnic failure. The spontaneous breathing trial was successful, except that they developed hypercapnia. So they did not develop hypoxemia or anything else, but they became hypercapnic. Despite the fact that they became hypercapnic, they were extubated, and extubated to non-invasive ventilation or just standard of care. And the primary endpoint, it's a little bit complicated, but is the development of respiratory failure in the first 3 days after extubation, and that is at least 2 out of these 5 items. So the primary endpoint, development of acute respiratory failure, 48% of the patients in the control group and 15% of the patients in the non-invasive ventilation group. And in the control group, there were more patients that required non-invasive ventilation, but there was no difference in the number of re-intubations. So that's interesting, right? Patients develop hypercapnic respiratory acidosis during SBT. You extubate anyway, and you continue with non-invasive ventilation of standard of care, and there's no difference in the number of re-intubations. And interestingly, but I'm not sure if I completely understand this, they did not find a difference in ICU or hospital mortality, but there was a significant difference in 90-day mortality. Well, it's not a primary endpoint, but it's interesting, I guess. And a rather similar trial was published a couple of years earlier, which was, I think, even more provocative. It was a multi-center RCT, patients with hypercapnic failure, that actually really failed a spontaneous breathing trial. And what they wanted to investigate the role of non-invasive ventilation as an early weaning technique in hypercapnic failure patients. And this is what they did. So the patients failed an SBT, all hypercapnic patients, and they were weaned with invasive ventilation, with face mask oxygen, or non-invasive ventilation. And the primary endpoint was re-intubation in 7 days. And interestingly, this was not different between the 3 groups. So if a patient with COPD fails an SBT, you just extubate and go to non-invasive ventilation or oxygen therapy. There's no difference in the number of re-intubations. The total time of ventilator support was longer in the non-invasive group compared to the invasive group. So, I mean, you have to consider for yourself a little bit. So what do you like? Being extubated real quick, but a little bit longer on non-invasive ventilation, or just do the weaning with invasive mechanical ventilation? I think it depends a little bit from patient to patient, to be honest. But I think this is a very interesting and provocative trial. Unfortunately, I think we have to end, but this slide actually summarizes it all. I mean, the role of invasive ventilation, non-invasive ventilation, high flow, in the whole trajectory of these patients with COPD. And this is my last slide. What I try to discuss is, for patients with exacerbation of COPD, first line of respiratory support is still non-invasive ventilation. Tons of evidence out there. With intubation, really try to limit hyperinflation, and I really recommend you to measure it a couple of times a day. I am careful here, but I really think if these patients develop pneumothorax, you should think by yourself, is this something that I could have prevented? And I basically think by far most of the cases, you could have prevented it by measuring hyperinflation and accepting hypercapnic acidosis. PEEP titration we discussed extensively, and we discussed the role of post-extubation non-invasive ventilation in these patients, which I think is fundamentally different from patients with hypoxemic failure. Any questions, comments? Yes, please. Can we have a microphone over there? Looks like they already went for lunch, so you want to take the microphone?
You didn't admit pressure control ventilation in the beginning. Why did you choose? And what's the volume control?
So the question is, why did we choose volume control instead of pressure control? It's a good question. I think that assessing the mechanics in volume control is a little bit easier. To be honest, I love this mechanical ventilation in patients with COPD, and we assessed airway resistance quite often. We assess the effects of bronchodilation on airway resistance, and you can only calculate airway resistance in volume control with a continuous flow pattern, right? So that's the reason. I don't think there's any evidence to show that pressure control is inferior or superior to volume control. It doesn't matter that much. But just my preference for assessing the respiratory mechanics, that we use volume control. Yes, please? So the last account did... Yeah? Yeah, so when we do the spontaneous breathing trials, in general, we really do T-tube trials, to be honest. And there's a little bit of discussion. I mean, if it really fails quickly, we would do the next one with a little bit of CPAP. Yes, that's right. Yeah. Okay, thank you very much for being here.